Hello, my name is Dr. Gilles Salles from Memorial Sloan Kettering Cancer Center in New York. And during this session for Lymphoma Hub, we would like to discuss the current management of patients with relapsed refractory diffuse large B-cell lymphoma, how agents that are available may fit in this management, and review recent data that were presented regarding the combination of tafasitamab and lenalidomide. As you know, was we cure about 60 to 70% of patients with diffuse large B-cell lymphoma. When we look at patients with advanced stage disease, those patients that are with high IPI, mostly patients also who are older, we do see that there are patients with relapse or refractory disease that need further interventions. These interventions have been developed in the last 5-10 years, and moving away from classical salvage chemotherapy, a couple of new agents and new opportunities for patients have been made available for patients in different parts of the world. One of the first immunotherapy-based treatments that has made available for patients with relapsed or refractory DLBCL was a combination of tafasitamab, a CD19 monoclonal antibody, and lenalidomide. Again, let's come back to this antibody, tafasitamab. It is directed against CD19. It has been modified in the FC portion to increase ADCC and ADCP. And preclinical data indicated that when combined with lenalidomide, there was an increased power of this combination to kill cells by enhancing NK-mediated or T-cell-mediated and possibly also macrophage-mediated cytotoxicity or phagocytosis. The antibody as a single agent already had some activity in the relapsed refractory setting of B-cell lymphoma with an overall response rate of 26% in a phase 2 study. Based on this single agent activity, on the rationale of this combination, the L-MIND regimen was developed, combining tafasitamab and lenalidomide. Just to recall, the schema of this regimen was weekly administration with tafasitamab, with an additional dose at day 4 during the first week, then administration every 2 weeks for the first year, combined during this first year with lenalidomide and the intended dose of 25 milligrams per day, 21 days out of 28. In patients that had benefited from this therapy, tafasitamab will be continued every 2 weeks until disease progression, toxicities, or other events. So the trial enrolled 81 patients, which were representative of patients who failed therapy for DLBCL. The median age was 72. Most of the patients had advanced stage disease, stage 3-4 elevated LDH, and 44% of them were refractory to their last line of therapy. Based on inclusion criteria, there was a limited number, however, of patients with primary refractory disease. When we look at the result of this combination during the first analysis that were presented and published in Lancet Oncology, we found that the overall response rate was 60%, with 42% of patients achieving a complete response. But what was very interesting with this combination is that those patients that achieved a complete response has a sustained duration of response. We continue to follow this cohort with an update published at year 3 and another update recently published with 5 years of follow-up. And what we found was that indeed those patients achieving a complete response had a very long duration of response. Actually, they didn't reach the median, mentioning that the majority of patients remains free of disease recurrence years after years. So this was the proof that this immunotherapy regimen has a potential to be likely curative in some patients with relapsed or refractory DLBCL. Let's talk about the tolerability of this regimen. During the first year, there is a combination of tafasitamab and lenalidomide. There was a significant number of patients that needed dose adjustment in lenalidomide, decrease in dose, transitory interruption, and that's what I do in my own practice, sometimes even in elderly patients or patients with comorbidity, starting at a lower dose of lenalidomide. Why is that? Because the majority of the toxicities that were encountered were actually probably those linked to lenalidomide or to the combination. The vast majority of toxicity were in fact hematological, such as neutropenia, anemia, or thrombocytopenia, including some grade 3-4 toxicities that need to be managed. There were also some side effects that are commonly associated with lenalidomide, such as rashes, GI symptoms, and a few others like that. What was important to know is that when you adjust your lenalidomide dose or schedule, usually this regimen is easy to manage. And what is important, and this is a particularly outpatient regimen, the patient do not have to spend any night in the hospital, which is different from other immunotherapies developed in the past or currently developed. Another point is that when we reach this 1-year mark and patients who have a PR or a CR can continue with tafasitamab consolidation, 1 injection every 2 weeks, the toxicity markedly diminished, and very few patients had really grade 3-4 events. And this regimen during that period is quite well tolerated. We have seen, again, that based on this phase 2 data, with mature data, the median PFS of this patient was of 1 year, and the median OS about 2 years with mature data. So obviously, this was a phase 2 trials, and there was discussion regarding the representativity of this patient in real world and whether this result will be reproduced. And different papers and presentations has been made since that time. Some, including ours, came from academic centers that probably recruited more difficult to treat patients, showing, unfortunately, poorer result in this patient. But recently, during the ASH 2024 meeting, a real-world data of 180 patients treated with tafasitamab lenalidomide, mostly in the community regimen, were presented. And again, the overall response rate was similar to what was observed, 60 to 70%, maybe a lower CR rate, more in the range of 10 to 20%, depending on the characteristic of the patient. But again, a median PFS that is around 1 year in this patient. What is important is when do we should use tafasitamab lenalidomide if we choose to use this regimen. And based on the phase 2 data, but also on this real-world experience, it is clear that this is in second line of therapy where patients benefit the most of this regimen. So you should think about that when a patient had relapsed after having received only R-CHOP. Obviously, patients that are really early refractory probably will not be the best candidate for this regimen, but the other ones that relapse after a free treatment interval are good candidates. And again, based on the phase 2 data on this real world, these are the patients that had the stronger benefit. All the criteria, including patient with limited stage disease, patient without bulky, patient without comorbidities, those are the ones who benefited most of the regimen. So there are other questions that are raised regarding this regimen is, what have we understood regarding the mechanism of resistance? Well, I will say that there are few data in this area, but probably one important one is that looking at patients who relapse or progressed after being exposed to tafasitamab lenalidomide, there haven't been a demonstration of CD19 loss. So the target antigen appears to be preserved, leaving to this patient eventually other options, so that CD19-directed CAR T cell, if they will be eligible for this regimen. This is different from what other immunotherapies are achieving in the field. Regarding the use of tafasitamab and the sequencing between this regimen and CAR T cell, there is, in theory, the possibility that using a CD19-directed therapy by 4 CAR T cell may prevent the efficacy, but this has not been shown in clinic, And there are, in fact, some experimental data in animal models suggesting the opposite. My recommendation, if you consider that you want to use this regimen before discussing CAR-T regimen in patients, is that you plan to have a treatment-free interval of tafasitamab for a couple of weeks before infusion of CAR-T, probably 3 to 4 weeks, the time from apheresis to injection, for instance. And there is some indications that, again, this combination may work in patients who have failed CAR-T cell therapy. Again, not those with early failure, but those with late failures that still exist. So in conclusion, this is clearly a regimen that has its role in the management of patients. How does it fit with the other possible and available regimen in patients with diffuse large B-cell lymphoma? Obviously, recently, we have learned that in patients with primary refractory disease, patients with early failure who are candidates for autologous stem cell transplantation, CAR-T cell provided a significant benefit as opposed to autologous stem cell transplantation. And we know that CAR-T cell can be used later in patients that are non-transplant eligible, providing interesting response rate, CR rate, and duration of benefit. However, access to CAR-T cell remains challenging in some regions. It's also a constraint for patients and constraint for their caregivers, and they have to move to a CAR-T centers. So tafasitamab lenalidomide is really an option that can be delivered close to home. I think that the comparison of tafasitamab lenalidomide with other second-line options has not been directly made, such as R-GemOx or R-Bendapola, but I will say it's probably a better option to use these immunotherapy regimens in the second-line setting or the third-line setting than repeating chemotherapy. The newcomers in the field are obviously the bispecific antibodies that are targeting CD20, a different antigen. They are also very active. They are mostly available in the third-line setting. So, sequencing the new agents in the relapsed refractory setting is going to be a discussion with your patient, a discussion on what's the optimal regimen for them, depending on their disease, their willingness or not to go to CAR-T at what time. And I will say that, again, in the second-line option, we do know that tafasitamab lenalidomide provides an opportunity to achieve, for those patients achieving a CR, a very prolonged duration of CR and probably a chance to keep the disease away. So again, many options which are good for our patients and good news, and discussion with patients and considering the different options that are available for us, including these options, is probably one of the good ways to try to help our patients navigating through the relapse or refractory setting in diffuse large B-cell lymphoma. So continue to connect to the Lymphoma Hub platform. There are informations regarding new publications and new development in the field of lymphoma. And I hope that this video will have provided some insights useful for your practice. Thank you for being with us.